Okay, it's 6:30 now. Should we start?
Okay.
So good evening to you all, and thank you very much for joining us in this centenary free paper series. Our focus today is in colorectal surgery, and we're delighted to have several talks. I'm very honored to have my co-moderator today as Krishna Singh. He's an upper GI surgeon by trade, working at Brighton Hospital. I'm Nuha Yasin. I'm a colorectal surgeon working at Wolverhampton Hospital. So we've got a variety of talks all focused on colorectal surgery, and our first speaker is going to talk to us about diurnal variation of adenoma detection rates in colonoscopy. This is Khurram Khan. Khurram, the floor is yours.
Thank you. Can you hear me?
We can, thank you.
Yeah, thank you. I'm Khurram Khan, one of the upper GI registrars from west of Scotland. So I'll be talking about diurnal variation in adenoma detection rate in colonoscopy. As we all know that adenoma detection rate is one of the key quality indicator for the quality of colonoscopies, and the JAG recommends at least a minimum of 15% adenoma detection rate, and ideally over 20%. Can I have next slide, please? Next slide, please. Thanks. So we aim to see if there was a difference between morning and afternoon colonoscopy lists. That was the primary aim, and the secondary aim was to see if the difference was associated with any patient or colonoscopy factors. It was a retrospective observational study, spanned over a period of 6 months in 3 different endoscopy units within the same trust. We excluded patients who have had incomplete colonoscopy for any reason whatsoever, previous colorectal resections, pediatric patient, as well as if there was incomplete data set. We divided the patient into 2 groups, the morning and afternoon list, and we analyzed their demographics, scope result, as well as the pathology results if available. We defined the adenoma detection as a colonoscopy with at least 1 adenoma which was detected on pathology, not just a polypectomy. Next slide, please. Thanks. So these are the results. We identified 3,665 colonoscopies, 508 were excluded. Morning list had 1,599 patients, and afternoon list had 1,558 patients, so roughly even. These were carried out by 55 colonoscopists, 35 of whom were surgeons and 16 gastroenterologists and 4 nurses. The table shows that patient demographics, which was almost evenly matched between the 2 groups. Next slide, please. Thanks. This shows the subgroup analysis for various patient factors, and statistically significant p-value is for male patients aged between 60 and 69 years, Boston Bowel Prep score of between 7 and 9, and if the endoscopist was a nurse colonoscopist. All of these had better adenoma detection rate in the morning compared to the afternoon. And next slide, please. And this slide basically shows the overall adenoma detection rate. And in the morning, it was 18.6% for the whole cohort, as well, and in afternoon, it was 14.4% with a statistically significant p-value. So this proved that there is difference between morning and afternoon scopes with regards to the adenoma detection rates, and we should aim to possibly change our list for colonoscopy, perhaps targeting the more high-risk patient to be done in the morning rather than afternoon. Thank you. I'll take any questions.
That's great. Thanks very much, Khurram. I've got a couple of questions for you until other people have questions. So just starting with regards to morning and afternoon, why do you think these differences exist between the adenoma detection rates?
Well, we have some speculation, but nothing proven. Partly because we think in the afternoon, people are more tired, so they tend to perhaps concentrate less. The second reason might be, at least in Lanarkshire and in most hospitals, in the morning, you'll have a tea break. and then you'll have a lunch as well in the middle as a buffer. So you can sort of run into a lunch break, whereas for the afternoon, everyone wants to finish at 5 o'clock. So there's always a time pressure more in the afternoon list than the morning list.
So just to follow on from that, so you've got surgeons, you've got gastroenterologists and nurse endoscopists.
Yep.
Out of the, in your data, the 4 nurse endoscopists had better adenoma detection rates. Did you look at the length of the procedures? Were they more lengthy when a nurse or a gastro consultant did the procedure?
No, that's very interesting, and no, so we didn't look at the length of a procedure or in particular the withdrawal time. Unfortunately, that was not recorded, so we don't have that data for this study.
That'd be interesting to look at. And finally, with regards to the points on the list, so in some hospitals they have more points in the morning compared to the afternoon to reduce precisely these kind of human errors for adenoma detection rate. Is that the case in your hospital?
It is not, unfortunately. 12 points, so 6 scopes, and if it's a therapeutic, then you can have 3 points, total 12 points. So you might have, if you're lucky, 4 patients, but usually 6 patients if it's not a mixed list.
Okay, and that's very interesting indeed. We do have a question from the shop floor, and I think we've already asked that. Why do you think there's a low detection rate in the afternoon compared to the morning? Perhaps a mixture of fatigue and
Do you want me to go through again?
No, I think that's fine. Thank you very much for your presentation. It's very interesting.
Thank you.
Thank you.
Thank you.
Good evening, everybody. Can you see me? I think, so we're going to move on to the next presentation, and that's will be given by Claire Rutherford, and the title is Reversal of Temporary Stomas, Incidence and Complications. Over to you, Claire. Thank you.
Thank you very much. So, hi everyone, I'm Claire Rutherford. I'm one of the registrars, also from the west of Scotland, and I'm going to be discussing our findings from our single centre, looking at our reversal of temporary stomas, the incidence and complications. Next slide, please. So, as you're all well aware, the role of temporary stomas is critical to protect distal anastomosis and minimise peritoneal sepsis. The aim of our study was to determine the incidence and complications in our own unit. So we prospectively collected data of patients undergoing elective reversals of stoma within our centre over a 24-month period. We assessed our patient demographics, the type of stoma being reversed, whether it was an open or circumferential approach, i.e. around the stoma site itself, whether it was a stapled or hand-sewn anastomosis, and the use of antibiotics at induction. So next slide, please. So I'm sorry, this is a bit of a busy slide. I was trying to stick to the 4-slide quota. So we carried out 69 reversals over a 24-month period. So as you can see, the vast majority were for ileostomies. And again, the vast majority of these were in the settings of malignancy, followed closely by diverticulitis, and more unusually for inflammatory bowel disease and ischemia. We had 3 of these which had nothing recorded for the indication. This was equally distributed between males and females, with a mean age of 59.3 and BMI of 26.8. We had a low overall leak rate at only 4.3%. We compared our colostomy and ileostomy complications, and as you can see, wound site infection, immediate complications, and length of stay were all statistically significantly worse in the colostomy group. When assessing open versus circumferential, the wound site infection rate again was significantly worse in the open group. However, immediate, delayed, and length of stay were all higher in the open group. They were not statistically significantly different. On the assessment of hand-sewn versus stapled, the wound site infections, immediate and delayed complication rates, and length of stay, again, there was no statistically significant difference between these. In terms of the type of complications that we were seeing, the vast majority of immediate complications were prolonged ileus, and the vast majority of delayed complications were incisional hernias. Looking at antibiotics and induction, this seemed to play no role in terms of our wound site infection rates. Next slide, please. So in conclusion, the versulostomas does have a significantly high potential complication rate, particularly in the setting of colostomy reversal and undertaking an open approach. Previous studies have also found similar outcomes, and in particular, there was no real difference in leak rate between the hand sewn and stapled. We had very small numbers. We only had 2 in the hand sewn and 1 in the stapled. But there was a reduced length of stay in the stapled group, which is down to what we think is increased gut motility earlier on. So the reason we undertook this in the first place was so that we could better inform patients of their risks, to give them better informed consent pre-operatively. So thank you for listening.
Thank you, Claire. Before we go on to the questions from the floor, and I think Nuha will coordinate that, I just wanted to ask, you had a group where they didn't have antibiotics. I thought anybody having reversal would have antibiotics.
Yeah, I found that slightly surprising as well when I was looking through, but there were a group of patients that didn't have antibiotics on induction, and I looked through the anaesthetic charts, through their kind of cardexes, through the op notes, and there were surprisingly a group of patients that didn't receive it, with no apparent explanation as to why this was, but it did seem to be operator dependent.
Interesting. Well, they didn't come to any harm by the look of it. Okay, excellent. Nuha, any questions, please?
If I may, Claire, a very interesting study. With regards to your colostomies, were they loop colostomies or end colostomies? Are these Hartmann's reversals, or I don't understand the nature of the colostomies. Sorry if you've already mentioned it.
The vast majority were end colostomies. I think actually all of them were end colostomies. I should have probably included that. But yeah, the vast majority were end colostomies for diverticulitis. I think we had 1 loop colostomy in the cohort, but yeah, you're quite right. The vast majority were in the setting of Hartmann's.
Yeah. So I guess my question is, do you think it's comparable? Can we compare a reversal of a loop ileostomy to a reversal of Hartmann's, essentially? The kind of 2 different procedures.
Yeah, completely agree. The rates of complications are significantly higher in the colostomy group, and maybe, yeah, they should be looked at as a separate entity. But as you can see, the vast majority of the cases that we were doing were in reversal of ileostomies. I think 54 of our patients were reversals. So the numbers for looking at colostomy rates were very, very low, so might indeed have skewed the data. But the meta-analysis that's quoted here has very similar findings in terms of their complication rates. So although it's small numbers, it is comparable with data that's already been published.
Yeah. It's a very interesting study. I think it'll be nice to just have them as 2 separate studies, because they're 2 separate entities at the moment.
Thank you.
From the shop floor, somebody was asking about the rate of AKIs in the ileostomy group. I'm assuming that's prior to the reversal of ileostomy. And perhaps if I can expand on that question, was the reversal of ileostomy perhaps driven by having AKI high output stomas in your subgroup analyses?
Yeah, so I have to say we didn't specifically look at acute kidney injury in terms of indications for surgery. The vast majority of the time it was driven by patient decision making rather than high stoma outputs. That was the kind of vast majority that we find in our clinics, but we haven't specifically broken that down. But again, you're quite right. That would be useful to look at.
Thank you very much. Very interesting study. Thanks, Claire. So moving on to the next speaker, we have Hannah Sellers. I mean, we have a lot of people from Scotland. Well done, guys. Very interesting study. So Hannah's going to talk to us about early experience of video consulting for new colorectal patients. Very timely, seeing that we're doing a Zoom talk at the moment. So the floor is yours, Hannah. Thank you.
Thank you very much. Yeah, so good afternoon. My name's Hannah. I'm a surgical registrar. I was in Inverness and now I'm Reading. So this presentation is on the early experience of video consulting for new colorectal patients. Next slide, please. Great. So face-to-face consultations are really designed around the clinician and our efficiency, but less so the patient. If we can click next. Thank you. So actually there's a good body of evidence out there suggesting this really isn't very convenient for the patient at all. Generates lots of anxiety and stress, and it doesn't give a very positive experience for many of our patients. Can we click next? Brilliant. So why isn't it sort of everywhere already? So there are a number of concerns across the profession, and there's very variable enthusiasm locally as well. Is it right to click next? So what we did, we tried to do a pilot just to appease some of the concerns and for ourselves to see whether this was feasible. So we screened referrals beforehand. People who we thought needed an examination were excluded. And for those that were deemed suitable, we offered a video consultation. The first 50 patients that said yes, we reviewed their records to try and sort of see how the service was working. Next slide, please. Great. So you can see a third of the patients were from over 100 miles away. This is a very big area, NHS Highlands, and 8 would have required flights or ferries to get to us. 40 of the referrals were urgent and most were query malignancy. And there were 2 options for the patients. They could dial in from home using a computer or phone, or they could go to one of the local GP surgeries or rural hospitals where we've got booths set up, and they're also staffed with a nurse to support them using the service. Next click, please. You can see in age-wise, so using the Near Me service, we had 10 patients over 75. And a fairly wide distribution of ages and equal genders in each group. And click next, please. That's grand. And really, the most important thing, so 7,500 miles saved in travel, including 200 hours of travel time. Those carbon footprint numbers are equivalent to almost 3 return journeys to New York. And that's from Inverness via Heathrow to New York. There were modest savings for the trust in terms of travel expenses that they normally have to pay out. However, we haven't done a balance in terms of costs expended for the service, but there were much better savings for the patient. And also, we haven't included things like food, loss of earnings, having someone with you, accommodation. So there's actually lots of extra expenses the patient would have to be responsible for. Next slide. So in conclusion, was the service feasible? Yes. Were there teething problems a bit with establishing video in 3 patients? Was there a learning curve? We definitely observed that the clinicians got more comfortable with it over a bit of time and using the modality. Was it safe? We really didn't find any safety concerns using the service. Patient satisfaction, we didn't measure formally, but we offered 5 patients further Near Me appointments, all were accepted, and we didn't get any negative feedback. And click, next click. That's brilliant, thank you. So coronavirus happened and the service massively expanded and allowed us to continue our outpatient services despite coronavirus was great. And half the patients actually never came to the hospital following their Near Me appointment. And those that did came for a particular service, whether that's endoscopy, a scan, pre-op assessment or theatre. So we had a lot less footfall in and around the hospital. Money saving, a bit unsure about whether it saved money for the hospital, but overall benefit. So they're really good time and travel and cost savings for the patients. And then there's these environmental advantages as well. We also noticed a lower DNA rate in the patients using Near Me service. Will we continue to use it? Definitely, I think it's now intrinsic to our service. Will it replace face-to-face? No, I don't think it ever will. We are looking at doing further work around training clinicians to be more comfortable with it straight from the off, and also investigating patient feedback. And that's it. Thank you very much.
Thank you, Hannah.
Thank you.
Thanks, Hannah. That's an excellent presentation yet again. So, Hannah, your age range for your patients is quite wide. It's 36 to 90. Were there any differences between, the perceptions or patients' experiences depending on their age?
Well, because we didn't collect any formal feedback, and it's a sort of weakness of what we did in a way, it's slightly uncertain. I think we'd see the 10 that attended the medical centres and the rural hospitals were older. So they were the guys at the upper end, the sort of 80 and 90-year-olds. And I think it really helped having a nursing staff there sat next to them. We had one patient who was really quite deaf, and we were very grateful that he was in a GP surgery. So the nurse relayed everything back and forth. But it worked well. It wasn't a problem. So I'd hope it's a good service for those guys in particular, the older population in particular, because the arduous travel from them from like Western Isles to ourselves, including flights, is really is a real stress, and a risk for them.
Sure. Your presentation has gathered a lot of interest. So we've got a few other questions. I think the first one is the platform. What platform have you used? Because clearly it's been successful for your current study.
Yeah, it's the NHS Near Me platform. So it's partly a project with NHS Scotland, and the company underlying is actually one from Australia that runs a service for rural hospitals based there. NHS Near Me, all the software is online, so the patient doesn't have to download anything. There's no platform that they have to use. It's they just sign on to a website and they're given a sort of login, and they can do trial runs, so they can sign in earlier and ask to speak to someone and practice beforehand. So we found it a very good service, and it's got all the security built in.
Sure. And with regards to the clinics themselves, did they run on time? Were you able to control the timings of the clinics?
Yeah, so they have a virtual waiting room. So actually they usually run pretty well, and we can be a bit more flexible. We run pure near me clinics. We also run hybrid clinics because all the setup is in normal outpatient rooms, so we can flip from one to the other, which is useful. And it doesn't save time though. It won't save the clinician time. A 20 minutes appointment is a 20 minutes appointment, whether using near me or face to face. But yeah, we found it ran smoothly, and it's probably, if anything, a bit more flexible.
Did you have any scoring system to be able to justify who undertakes which investigation, or in fact, actually just going back a step, who's suitable for a virtual consultation?
Yeah, I think because this was a pilot, we were quite conservative. So anyone that we had an inkling might benefit from an examination, we brought in for face-to-face. But really, if anyone, I guess any of the people who were query malignancy, colon cancer, who, in some places may even go straight to test, realistically, were really suitable for being seen. And I think actually now we're probably going to expand that remit and see more people, apart from now very few people who we think really need an examination on the first visit, because I don't think you lose a lot. You can counsel the patient, you can create a rapport before, heading down one direction or another.
Sure, and perhaps gather some formal feedback and make this into a qualitative study.
Yes, that's in progress. So someone's running on with that.
Perfect. Thanks, Hannah. Thank you very much.
Thank you very much. Thank you.
Thank you. So moving on, so the next presentation is improving lymph node characterization and detection using contrast-enhanced magnetomotive ultrasound. And Sandra is joining us from Sweden to tell us all about it. Thank you, Sandra.
Yeah, indeed. Hi, everyone. This talk will be about a novel imaging technique from a biomedical engineering perspective. Next slide, please. Lymph node imaging is an important indicator for rectal cancer spread, but with clinically available methods like MRI, lymph nodes are challenging to image, let alone characterize. Without information about lymph node status, major surgery must be performed in order to ensure complete oncological treatment. Advances in imaging and use of biomarkers could potentially lead to targeted surgical resection and improved quality of life. Stiffness is one potential marker. Stiffness is relevant to treatment options in pancreatic, breast, and liver cancer, and has been linked to pathology and phenotype in colorectal cancer as well. This motivates investigating new imaging methods. We report on this novel imaging technique for sensing tissue stiffness called contrast-enhanced magnetomotive ultrasound, CE-MMUS. MMUS is a preclinical technique that can generate contrast-enhanced images in real time with local information about tissue stiffness. It works by using a magnetic contrast agent and field to generate minute movement in tissue, and this movement is imaged using ultrasound. Here we can see the colored MMUS overlay highlighting the first draining lymph node. Next slide, please. Microbubbles are routinely used as an ultrasound contrast agent and can transport drugs and even mediate uptake through membranes. Magnetic microbubbles would retain these useful properties and respond to a magnetic field. In the current work, we're using computer simulations to look at how the signal amplitude depends on tissue stiffness and on type of contrast agent. The two types are A, evenly distributed magnetic material nanoparticles, and B, magnetic material confined to a microbubble shell. The main outcomes were 1, tissue stiffening reduced the motion amplitude by 64%. The relation implies that it would be possible to sense tissue stiffness based on amplitude, and that this would be more sensitive for softer tissues. And 2, bubble configuration seems preferable to free nanoparticles in terms of amplitude. Next slide, please. CE, did you advance the slide? Thanks. CE-MMUS combines lymph node imaging with tissue stiffness sensing, and this could be beneficial for rectal cancer staging. This imaging technique will be explored further in animal cancer models to define its clinical applicability. Please feel free to contact me or my colleagues about the project after this session, and thanks for listening.
Thank you very much, Sandra, and thank you for keeping to time. So very interesting indeed, but I'll let my colorectal co-chair ask you a question or two about the technique. Over to you, Nuha.
Thanks very much. I think both of us have the same experience, and the expert in the field currently, Sandra herself. Very interesting study indeed. With regards to the tissue stiffening, did you specifically for the rectum, did you find any difference between patients who had previous radiotherapy compared to virgin rectums, if you like, or was that not part of your study?
And this is not part of the study, but there is another study out by a different group that I think has some information about this.
It would be quite interesting to see if the compliance is lost post chemo radiotherapy, even if the radiotherapy was for prostate or not just for rectal cancer. Very interesting study. Thank you.
Cheers.
Okay, and if there are no other questions from the shop floor, we will move on to our next speaker. Thanks very much, Sandra, for your talk. Our next speaker is Jone Pearson, and it's a group from Scotland, yet again, from Glasgow, talking about defining standards in colorectal optimization, the DISCO study, to achieve international consensus on the key standards for colorectal surgery prehabilitation. Jone, very much for joining us. The floor is yours.
Can you hear me okay? Okay, perfect. So hi, my name's Iona. I'm a final year medical student at the University of Edinburgh, and I'm part of the DISCO study group. I probably should have put everyone else's names down there, but I forgot about that. So DISCO is an ongoing project. It's a study, as said, looking to formulate a list of key standards for colorectal surgery prehabilitation. If you go to the next slide, please. Oh, and then click 3 times. Perfect, that's perfect. So the reason that we're focusing on colorectal surgery is because colorectal surgery is very common as an elective procedure for both benign and malignant conditions. So that's very common in the UK. So there's a lot of patients that this could potentially benefit. Prehabilitation, I'm sure a lot of you might have heard of this before, but it's essentially optimization of the patient before an elective surgery in order to improve post-operative outcomes. So typically this would just involve physical activity, but there's actually scope for psychological and dietary input for prehabilitation, just to get a really holistic optimization before the surgery. And the role of DISCO is to set out a list of standards that should be used in all future prehabilitation programs for colorectal patients, so that hopefully there's more consistency across the country, and this would allow better, higher quality comparative studies in the future. Okay, next slide, please. So, as I said, DISCO is ongoing, so it's a 3-stage study, and we've completed stage 1. So we've got our long list sorted. So the long list was produced by a systematic review of the literature, and we performed a patient and public involvement day. So that was performed this time last year, and from that we've generated a long list of standards, and that is then going to be taken into phase 2 of the study. So phase 2 is a 3-round Delphi survey online. So that's going to be done using SurveyMonkey, and we're hoping to do that towards the end of this year. And then once we've got consensus from those and we've generated a shortlist, there's going to be a consensus meeting with key stakeholders and to create the final list, and then hopefully we'll publish and disseminate those. Next slide, please. Yeah, and then if you could click all the way through, thank you. So the PPI day, this is what we've completed so far, and we went in with these 4 key questions that we wanted to answer, and we asked, it was a semi-structured event, and where we asked the patients and the public who were there what they thought about these, and then we've analysed the results from that. It was transcribed, and essentially the answers that we've got. So for the individual components of prehabilitation, people are looking for physical activity, psychological support, and dietary input. It was unanimously agreed that this should be offered to all colorectal patients who are undergoing elective procedures. Who should deliver prehabilitation? This should be done by a multidisciplinary team. So that's from your surgeons, oncologists, nurse specialists, but then one of the things that was highlighted by patients at the PPI day was that they would really want other patients to be involved, and family members. And then the key outcome measures that were important to those at the PPI day were non-invasive testing. So they didn't want CPAT or anything like that. They wanted non-invasive measures of physical fitness and physical activity capabilities. And then something they were really keen on was the length of time to regain quality of life from before the surgery. And that was preferable to looking at length of stay or frequency of complications. And hopefully we'll be moving on to phase 2 of the study, and that's our Twitter handle down at the bottom if you would like to find out more or get involved. Thank you.
Thanks very much. I know that's a very interesting study indeed, and well done you for getting involved during your medical school. So that's brilliant. What do you think the importance is of involving patients in research in general? Is it important?
Oh, it's hugely important. Yeah, I think as typically this might not involve patients, and it might just be asking different like medical professionals and healthcare professionals, and often they might have different opinions on what is important to the patient. So that was something that was highlighted in the PPI day. The facilitators, who were all healthcare professionals, had like very different answers to some of these questions compared to the patients and public. So that was interesting to highlight. And obviously it's the patients that this is going to involve in the future. So we want to gear it towards them.
Exactly, absolutely. And what happens when you think there's a mismatch between what the clinician feels is important as an outcome and what the patients think is important for them? For example, you mentioned CPET testing, which for a surgeon might be very important, and the anaesthetist, but the patient might not want an invasive procedure. How do you handle that?
Yeah, I think that's quite a difficult thing to handle. I suppose you have to try and reach a compromise. What we are hoping for is, so that's something that will go forward into the next round. So we're looking to reach consensus on the standards for that. So we'll have patients, public and healthcare professionals will all be invited to reply to the survey, and hopefully a consensus will be reached, and there'll be something that is suitable for both.
Brilliant. Thank you very much. We look forward to a couple of stages. So thanks.
Thank you.
Okay, thank you. So the next paper is redefining standards of performance of low volume colorectal unit, and telling us about it is Sho. Sho, are you there?
Yes, I am. Can you see me and hear me?
Yes, we can.
Fantastic. All right, thank you. Hi, good evening. I'm Shoki. I'm one of the clinical fellows working at Harry Myers Hospital. I'll be talking today about our study entitled Redefining Standards of Performance in a Low Volume Colorectal Unit. Next slide, please. With the centralization of pancreatic and esophageal cancer services showing good results, there have been increasing talks about centralizing colorectal cancer services too. Some research argues that the increased hospital volumes and practice volumes of surgeons help improve patient outcomes following colorectal cancer resections, whilst other studies suggest that maybe other factors play an important role too. As such, we aim to study the short-term outcomes of colorectal cancer resections performed in our district general hospital as compared to a tertiary center. We look within a 30-day kind of period for this study, post-op. It was a retrospective analysis over a 3-year period, and the 4 variables we studied were the median length of stay, anastomotic leaks, post-op ileus, and 30-day mortality. These results were then compared against the Scottish national data as well. Next slide, please. So in this study, we had 150 elective patients and 29 of them were emergencies. To remove any possible age bias, we divided them into an over 70 age group and a less than 70 age group as well. As you can see, in the elective patients, the older patients tended to get a higher frequency of post-op ileus, whereas the younger patients somehow seem to have more anastomotic leaks. Not quite sure why. Mortality and length of stay did not differ too much. The sample size for emergency patients were relatively smaller, but it seems as though that older patients tended to have a longer median length of stay as well. On the whole, the mortality rate was 1.7%, and a rate of anastomotic leaks were under 5% at 4.6% in the elective group and 3.3% in the emergency group. Next slide, please. So, various European systemic studies have shown some amount of volume outcome relationship following colorectal cancer surgery, but in some papers it appears quite small, sometimes non-linear and also subjective, especially with regards to the definition of what constitutes high versus a low volume. Furthermore, 2 Dutch studies as well have suggested that high volumes do not necessarily guarantee better outcomes too. In our study, performance indicators were comparable to that of tertiary centers and national targets. However, we think that multi-center analysis may help further validate this observation. Also, we think that non-structural hospital factors play a major role too. For example, it's well recognized that age and comorbidity as measured by, for example, the ASA and Charlson Comorbidity Index are indicative of the risk factors in patients as well, while some studies as well have also argued that individual surgeon volume and specialization, regardless of which hospital they work in, are protective factors as well. On top of that, hospital protocols in terms of, let's say, pre-op and post-op risk assessments and preparations and monitoring also help in terms of patient outcomes. As long as all of these are in place, and unless it is a complex case requiring tertiary center input, we still do think that district general hospitals have got a role in the management of colorectal cancer. Thank you very much.
Thank you, Sher. So obviously the whole thing about centralization has been going on for some time, and for some tumors it's very clear that yes, small, because the number of the cases who present are small, therefore it makes sense to centralize. The difference with colorectal is, of course, you get a number of cases plus coming in as an emergency. So my question to you is that you've not shown any sub-analysis to see whether it would make a difference if you were to take out just the low anterior resections, because there's a suggestion that those might be the patients who may need specialist expertise. Do you think there is a role there?
Yes, because especially in our case over here just now, and we do have a wee table that further divided, you know, the tumor sites that warranted surgical resections, and rectal cancers were definitely one of the smaller numbers as well. So it definitely does provide scope for further study in terms of, you know, whether centralization for, let's say, rectal or rectal anal cancers would, you know, provide a sizable patient, you know, benefit in terms of surgery as well. Yeah, that one we definitely should look into.
Okay, thank you. Nuha, over to you.
This is a very interesting question that's been long-standing for some time with regards to centralization, low volume, high volume. The real question is what is it about a high volume center that makes the outcomes better for patients in general? And what is the definition? What's your cutoff? What makes a center high volume? What makes it low volume?
All right, so in our literature review, the various definitions kind of vary. For example, in the Dutch studies, they talk about, let's say, around 50 give or take and versus more than 100. In our case, we prefer, let's say, low volume being somewhere around 60 to 100, and maybe high volume. Ideally, it should be somewhere much higher, let's say 180, 200. But this would have to be based on, you know, the national situation as well. And your next question as well, what was your previous question again? I'm very sorry about that.
Why do you think the high volume center, why do people do better in a high volume center?
So high volume centers, in my experience, tend to be tertiary centers as well. That's where we tend to get, let's say, surgeons who are more familiarized with, let's say, complex patients as well. For example, you know, we have, that's right. So what we think is these surgeons who are more, and the medical teams and the nursing teams as well, tend to be more familiar with patients who come from, let's say, complex backgrounds or have got complex surgical pathology as well. So sometimes we wonder if that plays a role in terms of, you know, patient outcomes as well, especially with, let's say, secondary district general hospitals referring complex patients to them. We think that plays a role as well, just experience and things.
If the center can deal with the complications, that's how patients do better, really. But I think upper GI have seen more of this, Krish, than we have in colorectal with regards to centralization of services. In your study specifically, a question from the shop floor, were the oncological outcomes also compared? Was it just the clinical outcomes?
So we did compare on resection. We did look into resection margins as well, and also further clarification into whether there were presence of metastases and also clavia and dindo. In terms of clavia and dindo, we still see the most large majority, over 50% of them in both the elective and emergency ones. Over 50% had a clavia and dindo classification of 0. Metastases-wise, over 90% of them show no metastases, and tumor resection margins as well were quite good as well, with only about 3 or 4 out of the whole data set having an R1. Most of them, the vast majority, over 96-97% were R0.
Okay, and finally, how do you mitigate against low volume centers, and you know, how do you improve the outcomes if you are a low volume center? I think the back to that question is, you know, in the UK, you have several DGHs and very few teaching hospitals. So you can't really centralize all services. So how do you ensure that your outcomes are good?
So one way to mitigate it is to have, let's say, the responsible consultant engaged in, let's say, MDTs with not only his other fellow colorectal surgeons in the hospital, but perhaps also with the associated tertiary hospital for further advice if they've got any concerns or queries, ensuring adequate preoperative preparation before the actual surgery itself as well, and also for the whole MDT to be, aware and provide good post-op monitoring as well. So frequently, I do see, for example, in my own consultants engaged in, multiple MDT discussions in complex cases, discussing whether it will be appropriate for, let's say, DGH management versus a referral to tertiary.
Sure. And in the non-so-complex cases, perhaps training, perhaps upskilling courses, and continuous education, as we are doing now. Thank you very much, Shu, for your talk. The next speaker is Campbell MacLeod. Campbell is going to talk to us about the FIT test and a business intelligence approach, another study from Scotland. Thank you, Campbell, for joining us.
Thank you. So good evening, everyone. My name is Campbell MacLeod. I'm a surgical research fellow based in Rigmore Hospital. And I'm going to talk about our FIT testing and our business intelligence approach. Next slide, please. FIT or QFIT was introduced in Scotland for symptomatic patients on the back of strong evidence that it could be used as a effective and safe triaging tool. As I'm sure everyone here is aware, it detects human blood products in stool, which then gives us a numerical result, which directly correlates with the risk of a patient harbouring any significant bowel pathology. It was introduced almost 2 years ago in NHS Highland, and our aim through this project was to collect 12 months worth of data to inform how we've used it since its introduction and potentially introduce some safety netting. And we wanted to do that in an efficient and accurate manner. Next slide, please. To do this, we've done our data collection as a business intelligence approach, which has involved a collaboration between clinicians and IT staff in NHS Highland. So we performed a multiple system data extract, starting with our lab database to extract all the QFIT results and associated CHI numbers for all patients. We've then used the CHI number to search other eHealth databases in our system, so TrackCare to obtain appointment, referral and admission data sets, our endoscopy management IT system for our endoscopy procedural data for colonoscopy and flexible sigmoidoscopy, and then finally the pathology database to get histopathology results for any samples taken from any endoscopy procedures. Next slide, please. So this is our what we're calling our FIT dashboard, which uses a program called Quick View, and it integrates and displays all our FIT data, allowing us to perform further analysis and safety netting. So as you can see, there's a number of subheadings there, which are fairly self-explanatory, and sub-selection boxes, which you can obviously select to sub-analyze the data via FIT band result to whether a patient has an appropriate referral to pathology result, and then interrogate each subset heading to gain CHI numbers. So you could look up a patient who had a FIT less than 9 who subsequently had an adenocarcinoma and look up individual cases. So for safety netting, what we've done is we've taken all patients who had a FIT greater than 400 and looked to see if they had a secondary care referral and investigate any cases where they weren't referred, and anyone who we thought it might be appropriate that they were referred, we've contacted the GP to alert them to make sure they were aware of the result. So our feeling is that we've managed to gather almost 3,000 patient records in an efficient and safe, accurate way. We've now set up the system to automatically update daily so that we only have to do this process once, so we can continuously update our results. Thanks.
That's a brilliant study. I think FIT at the moment, Campbell, is popular, very much so from a tertiary referral centre point of view. What do you think the role of FIT is from the primary kind of GP practice point of view? Is there a role at all, and should it be expanded, or should it be exclusive to secondary care?
Yeah, so in Scotland, at the National FIT meeting, I think all but one health board were using it in primary care. Our feeling locally is that that's where it's most beneficial, particularly for a negative FIT result, and that if GPs find patients who have a negative FIT result, and have a normal hemoglobin, that the evidence suggests that they're at an extremely low risk of having any underlying pathology, and that they should be reassured by that, and that follow-up FIT testing in 8 weeks if there's persistent symptoms should be found to be reassuring. From our results, however, we seem to still perform in a large number of colonoscopies in FIT negative patients. So we had 2,000 patients with a negative FIT and performed over 200 colonoscopies on them. I think there's still a lot of work that we could do. I think we still see a high number of referrals with negative FITs, and we have tried to reassure GPs locally that FIT is an extremely safe test. And I think particularly with COVID, that the number of patients undergoing investigation with negative FIT will go down significantly.
Sure. And what do you do with your symptomatic patients who are FIT negative?
So the current advice is that they, provided they don't have any red flag symptoms, that GPs adopt a watch and wait approach and can repeat a FIT in 8 weeks' time. I think we'll still continue to see referrals as endoscopy services recover.
Okay. And during COVID, have you changed the way you use FIT at all, or is this all pre-COVID?
So this data was the data that I collected over the 12-month period. It's still, like I said, automatically updating. What we're hoping to do is over a 12-month period have 2 sets of data so we can examine what's happened pre-COVID and then sort of post-recovery COVID time as well, and see if our rates of investigation have changed, and see if the rate of pathology pickup has changed at all, because obviously there will be a number of patients, a very, very small number of patients in the less than 10 group who will have a cancer, unfortunately.
Sure. Final question from the shop floor. We've got, what about follow-up FIT tests, a number of weeks later following a negative result? Is that beneficial?
So, yeah, some of the national guidance that's been helped to be produced in this sort of COVID recovery has been helped with, it's been in conjunction with Craig Mowat from Dundee, who's done a lot of the publishing on it. And he's got some unpublished evidence that he was suggesting indicates that would be beneficial, but I understand that it's not been published yet.
Okay, great. Thanks very much. That takes us very seamlessly to the next talk. We're going to the next session, which is the talking posters session. We have Sangram Patil, who's going to talk to us about colonoscopy and chronic diarrhea. Is it really necessary? We do have to stick to the times if that's okay, because we're just running out of time. So
yeah, okay. Hello, hi, good evening, everyone. I'm Sangram Patil, one of the surgical registrars at Pinderfield Hospital. So I'll be presenting today a talking poster, colonoscopy and chronic diarrhea, is it necessary? So as we all are aware of recent BHG guidelines published for investigation of chronic diarrhea, it suggests colonoscopy and biopsy is the preferred investigation in chronic diarrhea. So we aim to evaluate the role of colonoscopy in patients with chronic diarrhea. So we retrospectively reviewed a cohort of adult patients who were referred as a 2-week wait fast-track referral for change in bowel habit, mainly diarrhea, from GP setting between January and October 2019. So in total, 180 colonoscopies with biopsies were performed as per recommendations. The mean age of patient at the time of colonoscopy was 61.8 years with standard deviation of 13.4 years. 104 females and 76 males. So out of 180 colonoscopies, so 35 colonoscopies were abnormal, which is 19.4% of all colonoscopies. Out of these 35 abnormal colonoscopies, the most common findings were inflammatory changes in 14 patients, followed by adenomatous polyps in 11 patients, and microscopic colitis in 5, ulcerative colitis in 2, Crohn's in 1, and telangiectasis in 1, and anal cancer in 1 patient. So 95% of these abnormal findings were picked up from left colonic biopsies. So those are 33 patients out of 35 patients. So we think this diagnosis could have been made possible by flexible sigmoidoscopy. Interestingly, no patients were found to have colorectal cancer. So in conclusion, flexible sigmoidoscopy can be safely performed in patients with chronic diarrhea with careful evaluation of symptoms to improve overall patient experience. Thank you.
Thank you very much. We'll have one question from the shop floor. What's your opinion about random colonic biopsies in general?
Yeah, so these are all patients included as these are colonoscopies with biopsies. So we included only those patients who had colonoscopies and biopsies as per the recommendations. So random biopsies from right as well as left as well. And these findings are all from the left-sided biopsies.
I think I'd quite like to link your talk with the previous talk. The fit negative patients
Yes.
who are symptomatic, should they have colonoscopy or not?
Yes. That is in our next stage, because this is just a crude observational studies to look at the interesting findings of colonoscopies referred as chronic diarrhea. So we plan to incorporate other investigations like fecal colportecting as well as fit testing, and probably divide these groups in less than 40 and more than 40 years old, and that is on our agenda. This is ongoing study. Yeah.
Lovely. Thanks very much.
Thank you.
So I think we'll go on to the next poster, and that's a rather worrying observational study from Egypt, alarming incidence of early onset colorectal cancer in Egyptian population. So telling us about that is Mohammed Mustafa. Thank you.
Many thanks for having me in this session, and it's a pleasure to be with you today. So, colorectal cancer is traditionally considered a disease of older adults. However, the incidence of early onset colorectal cancer is rapidly increasing. In Egypt,
sorry, Mohammed, sorry, can I interrupt? Can you put your video on?
All right.
Good, thank you. Carry on, sorry to interrupt.
Yeah, no problem. In Egypt, observational studies showed a clearly higher prevalence of early onset colorectal cancer than found in Western world. So this study included all patients of age less than 45 years diagnosed with rectal cancer at the National Cancer Institute, Cairo University between 2008 and 2010. We found out the proportion of patients diagnosed with rectal cancer at age of 45 years or less constituted 37.6% in relation to rectal cancer patients at all age groups. In figure 1, it shows the age distribution in our patient, where patients were stratified into 5 age groups starting from 20 years with 5-year intervals, and other group of patients who are less than 20 years. The age group 40 to 45 years represent 26.7%. The age group 31 to 35 years represent 19.8%, and the age group 36 to 40 represent 18.8%. Our figure was considerably more than reported from the Western literature. For example, in the British Columbia study, they found that the ratio of patients younger than 30 years represented 0.47%. This means that roughly our young ratio is 100 times that in the British Columbia study. Regarding depth of tumor invasion in our patient, 62.8% had T3 tumor infiltrating through the muscle into the perirectal fat, and for lymph node status in the operative specimen, 40% of our patients didn't show lymph node metastasis, 31.5 had N1 disease, and the remaining were N2. The duration of follow-up was 36 months. Local regional recurrence was observed in 30% of patients who underwent resection, and 46.8% of patients become metastatic by the end of 3-year period. The median survival of our cohort was 26.8 months, and the median disease-free survival was 62.6 months. In conclusion, early onset rectal cancer is alarmingly high in Egyptian population. Further studies may establish the cause, indicate the link between risk factor and health outcome. Thank you.
Thank you very much. I think we'll have time for one question. Nuha, do you want to ask the question, please?
Yeah, sure. Mohammed, thank you very much for an interesting study. What do you think it is about the Egyptian population that's causing this phenomenon?
So this has been speculated. Many causes have been speculated. either environmental factors. They said it might be organophosphorus compound that they use in the agricultures. Some said that it's a hereditary causes, but there is no evidence of any of that. There are several studies who investigated that, but they didn't reach a solid answer for that.
It would be very interesting if you can follow this up with a rectal biomarker study and just
Yeah.
do the proper genetic profiling. And
All right.
Thank you very much. Thanks, Mohammed, for your interesting talk. Our next speaker is none other than Rebecca Nunn, talking to us about rectal tumor height. Gosh, how many times have we heard the debate about rectal tumor height? Are we all speaking the same language, Rebecca?
Not really, but I guess I'm probably not going to add much to what's already known and just reflecting our local practice. So today I'm just going to present the poster, Rectal Tumour Height, Are We All Speaking the Same Language? And this was based on some work that I did at my previous trust, which was at Watford Hospital. So essentially this was a single centre retrospective audit of elective rectal cancer operations over a year at our trust. And we were looking at measuring the preoperative rectal tumour height. So by rectal tumour height, what do we mean by that? Well, we essentially mean how low is the tumour. And in terms of that, there's different definitions. So National Cancer Institute would sort of define it as being the distance between the anal verge and the distal margin of the rectal tumour, whereas European Society of Gastrointestinal and Abdominal Imaging would define it as the height from the anal rectal ring to the distal margin of the rectal tumour. So obviously there's variability there in those definitions, and those few centimetres can make a huge difference when it comes to trying to sort of convey whether this is or ascertain whether it's a low, very low rectal tumour. And when counselling patients and preoperative planning, the height is extremely important with regards to is this likely to be a low anterior section, ultra low, or are we talking about an abdominal perineal excision of the rectum? So what we did was we were essentially looking to evaluate the consistency of our local practice in terms of landmarks referenced, and also when the same landmark was referenced, was there a variability in the recorded heights? So looking across at the results, essentially we found that for MRI, things were relatively consistent. So 91% of our MRIs had a rectal height measured from the anal verge, with 71% measuring from the anal rectal ring. When it comes down to endoscopy and clinical modalities such as digital rectal examination or rigid sigmoidoscopy in clinic, there was a lot of variability. So for example, a lot of the time, if a height was given, there was no reference landmark. And when a reference landmark was used in clinical letters, 17% of clinicians mentioned the height was from the sphincters, 22% the height from the anal verge, and 13% from the dentate line. What we've then done is using the cases that we were able to compare, i.e. where the same landmark was used for different modalities, we've looked to see what the variability in the height was. So for example, we gave MRI values a value of 0. So if we say the height from the anal verge was a value of 0, and then we compared that case to the other modalities where that was measured. So for example, with colonoscopies, we were able to compare 14 colonoscopies and MRI heights. And in that, although the mean difference was less than a centimetre, i.e. it suggests that on average, colonoscopy is overestimated by 0.7 of a centimetre. Actually, when we look at our actual numbers, the range varied from -5 centimetres to +6.4 centimetres, i.e. an 11 centimetre range, which is obviously huge when we're talking about rectal tumour heights. So in conclusion, we found that our local practice probably mirrored what's in the literature in terms of there is a lot of variability in how we measure our heights, how we communicate our heights, and actually there's a lot of variability even if the same landmarks are referenced. In terms of how we took this forward with our local practice, well, firstly, when we discussed this in MDT, there were some members who weren't as aware of this being an issue, and in terms of moving forward, it was agreed to add an additional line to the MRI reporting pro forma to also include the height from the anal rectal ring to the distal margin, just because practically speaking, the surgical cohort felt that that was the most useful when it came to planning their surgical approach for the rectal tumour. End. Oh, sorry, I can't hear you.
I've just done the typical mistake of not unmuting myself. Rebecca, thanks. That's a great study that you've just presented. One question for you, just one. Does it matter? Why do we need to know the height, the rectal height?
Well, I guess from two obvious things spring to mind. So one would be that in terms of planning, just knowing what the height's going to be. So to be able to go into an operation knowing the strategy and to have had that discussion with the patient as to whether or not they may prefer to go for, if it was very low, a complete excision and an end colostomy versus potential complications of having lower anterior rectal syndrome symptoms. So that's one. But the other thing, I guess, is just when it comes to sort of studies and research in the field and making outcomes comparable. You know, heights of the tumours may come into the decision-making process and what operations were performed. So if there was a bit more uniformity in that sense, I guess it's always good to try and compare like for like as much as possible.
Sure, but also in addition to that, you need to know what is a true rectal tumour, so that whether you're able to offer some neoadjuvant therapy or not, and you can only offer that if it was true rectal tumour. Excellent study, thanks very much.
Thank you.
And moving on.
Okay, yeah, so the next one is a comparison of short-term outcomes of single incision laparoscopic right hemicolectomy versus conventional multiport right hemicolectomy. We want to know if there's a difference between these two techniques, and Zishan Ahmed is going to tell us about it. Thank you. Oh no, sorry, is it Rebecca?
No, it's me, Zishan.
Ah, okay. Okay, thank you. Zishan, on you go.
Hello, everyone. My name is Zishan Ahmed, and I'm working as a Senior Clinical Fellow in Colorectal Surgery in Brussels Hall Hospital. Today I'm going to present one of our internal studies that we conducted. We tried to compare the short-term outcomes of single incision laparoscopic right hemicolectomy with the conventional multiport laparoscopic right hemicolectomy. Basically we introduced this single incision laparoscopic right hemicolectomy 2 years ago in our department. So the same surgeon was doing initially the multiport laparoscopic right hemicolectomy. So we already know that there are theoretical benefits of reduced postoperative pain, because obviously the number of incisions for the ports are reduced with SILS, and obviously when limited incisions, better cosmetic outcome is expected. But still in UK, the single incision surgeries are done very rarely. So we started the single incision versus the conventional multiport hemicolectomy comparison. So we had 13 patients in both groups. If you can see that there isn't any significant difference in the surgical time in minutes. The length of hospital stay could be prolonged in some cases, but overall the difference is insignificant. Anastomotic leak, yes, there was one patient who developed an anastomotic leak in SILS, but that was basically attributed to the low albumin level of the patient. The patient was had a low albumin level at the time of surgery. If you look at the demographics, they're very much comparable. Most of the patients were in the ASA 1 to 3. If we look at the readmission rate, it was almost negligible, within nothing there in the first 30 days. Reoperation wasn't there. The number of lymph nodes harvested, which is very important from oncological point of view, was comparable in both the groups. Resection margins were very much very much that we wanted in the cells group. So here we came up with the conclusion that the single incision right hemicolectomy is safe and effective in selected patients and in selected hands.
Thank you. I'll let Nuha ask a question rather than me wanting to know about this some more.
Well, I mean, we have chatted about this before.
Yes.
And what is the benefit, Zishan? Why cells versus laparoscopy? What is the true benefit for the patient?
The true benefit is that obviously the patient ends up with a single incision. He doesn't have the rest of the three incisions for the ports. So the patient ends up with a lesser level of pain as compared to the conventional laparoscopic right hemicolectomy. Theoretically, there is some benefit of cosmesis as well, but still the more important factor is obviously the pain.
So, I mean, I should be kind because this is the only study from the West Midlands, but I am going to ask another question.
Yeah.
So, technically, extraction, you know, your Sills port needs quite a large incision to actually put the gel port in.
Yeah.
With regards to your laparoscopic right hemi, was the extraction midline? Was it a transverse? Was
Midline.
It was
Midline, midline umbilical.
That incision,
yeah,
compared to a Sills incision?
So we use the same port that we use for extraction of the specimen in the conventional laparoscopic right hemicolectomy.
So that you're saying the length of the incision for Sills and for the extraction for a laparoscopic right hemi were the same?
The same, yeah. So the only thing that mattered sometimes was the sheath incision.
Okay, and with regards to the Sills itself, did you ever have to have an additional 5mm port, or was it true Sills?
I remember because I've been working in this hospital for the last 2 years, and this study was basically done by my supervisor and me. So I remember that just one case that I remember that we had to put in another 5mm port.
And otherwise, there's the equivalence between the two.
Yeah.
And there's a very, very good question from the shop floor from one of the attendees. How was it decided who goes for Sills and who goes for laparoscopy? Is there any selection bias? Did you use the slimmer ones for Sills, for example?
Yes. Yes. So if you have to be very selective in patients. So Sills in patients who are obese, Sills might not be that effective.
Okay, so there's a selection bias. It's a very interesting study. Perhaps your next one could be randomized and you're blinded as a surgeon as to which you can pick and choose, and let's see what happens with higher BMIs.
Yes, we are using Sills for Hartmann's reversal as well, and I've got a poster presentation for that as well later on. But the thing that we were doing here was that because it was done at a very primitive stage here, our consultant had started here, so maybe with time the level of experience increases and obviously the expertise increases, so this may be extended over to a bit more obese patients as well.
Excellent. Thanks, Zishan, in regards to everybody at Russell School.
Thank you.
Thank you. Our next speaker is Theo. Theo's been waiting patiently for the last hour and a half. Theo is going to talk to us about patient acceptability of a home colorectal cancer rule-out test. Theo, you're currently at Imperial, but your study was done elsewhere. Is that right?
No, it's part of my work at Imperial and Croydon. It's working with both of them there. So thank you very much. My name is Theo. I'm a surgical registrar in South West London, and we're going to talk a little bit about the patient acceptability of the FIT test, which we've heard about previously. So the FIT test is a quantitative fecal test which detects hemoglobin as a surrogate marker for colorectal cancer. There's mounting evidence of the high diagnostic accuracy of FIT in patients with high risk symptoms for colorectal cancer. The NICE FIT study demonstrated FIT could be used as a colorectal cancer rule-out test, and it is likely FIT to be introduced nationally to triage patients for referral. There's a paucity of patient-orientated research in the context of symptomatic patients. Initial recruitment data from NICE FIT pilot study in London showed that only 48% of invited patients completed the test and returned the FIT kit. Consequently, there's a need for a better understanding of patient attitudes towards the test in this context. The aim of this prospective study was to assess patient perception, variation in acceptability, and usability of FIT in patients with colorectal cancer symptoms. Following literature review, a questionnaire was developed through collaboration with a patient involvement group. Demographic information was collected along with 21 questionnaire statements covering 4 themes of feasibility of FIT, fecal aversion, patient knowledge, and patient future intention on a 5-point Likert scale. Questionnaire and FIT kits were sent to patients with suspected colorectal cancer symptoms as part of the NICE FIT study across 25 centres in England. Logistic regression analysis was performed to determine if there were significant differences in patients' test perception based on ethnicity, preferred language, age, location, deprivation index, and successful use of FIT. So 1,151 questionnaires were returned, 408 from London and 743 from the rest of England. There was greater ethnic diversity of responders in London, where 28% were from ethnic minority backgrounds, as opposed to 3% in the rest of England. There was also greater diversity in preferred language of participants in London, with 11% preferring a language other than English, compared to 2% in the rest of England. FIT was seen as practical, with 88% of patients in London and 91% of the rest of England agreeing it was straightforward to collect their fecal sample. Patients also agreed they prefer FIT to a colonoscopy. Significant differences in FIT perception were seen between demographic groups. Patients who used FIT correctly were 4 times more likely to find it straightforward to collect their stool sample and 4 times more likely to prefer to use FIT rather than undergo a colonoscopy. Patients in London were almost half as likely as those elsewhere in England to prefer to use FIT and undergo a colonoscopy. Preference for FIT over colonoscopy increased with age. Willingness to use FIT in the future was stronger in patients who successfully used FIT and those from white compared to non-white backgrounds. No differences were seen in patients' perception of FIT hygiene across ethnic backgrounds. So, in conclusion, FIT was acceptable to most symptomatic patients who were referred with suspected colorectal cancer symptoms. FIT was found to be practical and fecal aversion was not inhibitory to health behaviour. Despite this, significant differences in FIT perception were seen between patient groups, including those from London, younger patients, and those from ethnic minority backgrounds. Strategies to engage these patient groups should be incorporated into any programme that introduces FIT into the symptomatic clinical pathway. Thank you.
That's great, Theo. That's a great analysis. I guess the question is with regards to, I know you talked about the language differences, a couple of questions really. Were you able to provide the information leaflets in different languages, or how did you break that language barrier?
So in this study, because we were using patients who were taking part in a NICE FIT study, which was comparing the results of the FIT test to colonoscopy results. So as part of recruitment for that, it was only in English that we recruited patients. But part of my next work is to, and it's really a key thing, is to speak to the people who didn't reply. So they're the people who didn't engage, and they're the people who GPs have asked, them to do a FIT, and they just haven't, and then they've carried on their pathway. So as part of that, I think I need to be conscious of ethnic minority groups who can't speak English as well enough to engage. So they're the key people to target next, certainly.
Sure, absolutely. And apart from ethnicity, I mean, the other thing to look at is whether, more affluent or less affluent groups had better or less, or worse.
Yeah, I mean, interesting. We looked at the deprivation index, and based on our analysis, we didn't clearly see that was the case. And obviously, lots of factors go into that. So it may be that individual factors that make up the deprivation index do have some relevance. But from our analysis, that didn't seem to affect patients' perception, but certainly you can delve into the data even more to see if there were specific groups that were unfairly had different perceptions.
Sure. Excellent study. Thank you very much for your presentation. Thank you to everyone, all the panelists today for joining us and for your excellent presentations. I certainly enjoyed this evening. Thank you to my co-moderator, Krish, who's secretly a colorectal surgeon at heart. You've enjoyed it, haven't you?
We all are, all general surgeons. All surgeons are secretly colorectal. Thank you very much, everyone. It's been a great presentation for all around, so enjoyed that. Thank you to Bhav and Carol for organizing the whole meeting this evening.
Couldn't have done it without you. It's my first Zoom one, so I'm now, officially zoomed out.
You're a veteran now.
Just finally, please don't forget to just go onto the website. You can see our e-posters. I think one of your colleagues has put in a plug for his e-poster as well earlier. So do log in and have a look at all the other presentations and enjoy your evening. Thanks very much.
Thank you.
Bye-bye.
Bye.